All right, we're going to go ahead and get started. And I'd like to say three thank yous. First, thank you to the Kirschner family for sponsoring this and for the legacy that your dad left on. And I don't want to go on and on about Dr. Kirschner. I'm going to let Dr. Block talk about Dr. Kirschner. Dr. Block, can you say a few words? Because he has more experience working with Dr. Kirschner than I ever have. So,
Thank you.
Dr. Block.
Just a few words. I'm fortunate that I've been an attending radiologist here, believe it or not, for 65 years. And I knew Paul from my residency on, and he and others in the Department of Pulmonary Medicine and Surgery and Radiology got me and my friend Al Tierstein interested in pulmonary radiology. He went on to be a pulmonologist of fame. Paul was a great teacher. He was impatient to have people around him to be as perfect as he could, as he was. And he was a good friend from the beginning. When I wanted to practice, I was one of his radiologists. And I was fortunate to go over many cases with him in his office on 92nd Street. And to make a long story short, we were close social friends. Our families vacationed often in Cape Cod, and this is where I met his children. They were small, like they're now they're tall. And his wife, Charlotte, and my wife would be good friends. So it's a pleasure to introduce Paul's legacy, and he would be very proud to know that Claudia and David are today's lecturers. Thank you very much.
And I'd also like to thank Monica Kraft. It's not frequent that medicine and surgery come together, and I'm very thankful for doing this together with the Department of Medicine, and hopefully we can do much more together moving forward. Because we need all the disciplines, not just the radiology pioneers, but we need the medical people, the surgeons, radiation oncology. We need everybody working together to advance the field of medicine. And then I want to thank our Kirschner visiting professors today. So the Kirschner Lectureship has been going on for over 25 years. Actually, 26, this is our 25th year. And we wanted to do something special. We frequently will have experts from all over the world to come here to speak on topics, innovations, breakthroughs, etc. And when we were figuring out who we wanted for our Kirschner professorship this year, all the surgeons were brainstorming, trying to figure out who's the best person to have, who's made the biggest difference in lung cancer surgery in our field. And we're racking our brain trying to come up with a surgeon. And I said, listen, the people who have done the biggest for our field, or maybe been Kaufman, I can't even remember who was saying it, or maybe Wolf. And we were like, well, it's Claudia and David. And I was like, well, why not have them? Well, but they're from our own institution. So I can't think of anything better than to acknowledge greatness in your own institution, because frequently you overlook it when it's right underneath your nose. And so we have the two people that revolutionized this. Everyone's heard of the NLST, National Lung Screening Trial. But before you get a nice, well-run, randomized controlled trial, there are the pioneers before that break down the walls, that take all the heat, because it's heresy when you go against what is common knowledge in medicine. And it's not really what you don't know that hurts you, it's what you do know that's just not so. And so these guys just broke down the walls, and their own personal story is inspiring. And so here you have a girl via Queens who went to Forest Hills High School, born in Berlin, a Brooklyn boy from Midwood, and they're still here in the city they grew up in, making advances that affect the entire world. And I could go on, but for those of you that don't know, they are the pioneers of lung cancer screening. Before it was cool, before it was standard of care. And their methodology is being taken forward in surgery. So they figured out screening worked long before the well-packaged randomized controlled trial came out. And their methodology, Claudia has a PhD in biostatistics, and they figured out how to do this. And in three areas that have had the biggest impact. One is screening. One, they figured out that sublobar resection was just as good as lobectomy before the randomized controlled trial. And they also figured out that minimal node sampling was just as good as lymph node dissection before any randomized trial came out. So they knew about all these things. So that methodology is moving forward from IL-CAP to IL-CART, which is looking at treatment. And so you didn't come here to hear me, you came here to hear them. So without further ado, Dr. Henschke is going to talk to us about her journey, and then followed by Dr. Yankelowitz.
I don't know, Raja, you summarized it very well. I don't know if I can do this as well. So thank you very much for this honor. And we'll talk about the journey from 1990 and the lessons we learned along the way, and how do we take it together to a new level. That's wonderful that we have this multidisciplinary group, and together we can take it forward. I'll also say a few words about Paul A. Kirschner. He was a renowned thoracic surgeon at Mount Sinai. He made groundbreaking contributions to the surgical management, particularly mediastinoscopy as both a diagnostic and therapeutic tool. But he also believed in multidisciplinary approaches for improved patient management, including pathologists, pulmonologists, radiologists. We all need to work together to really make critical advances. And so LCAP continues to honor and advance Dr. Kirschner's spirit, both through IL-CART and IL-CAP. The main thing that you have to understand is it takes persistence, perseverance, and a team. A team is the key thing to keep things moving forward. And I just wanted to talk about a little bit, put you back, what the world was like in 1990 when we started thinking about this. Many of you weren't even born, but let me point out that Bush 41 was president, Dan Quayle was vice president, the Cold War had ended, Germany was reunited, Margaret Thatcher resigned, the Hubble Space Telescope was launched to explore the universe, and the Human Genome Project just started. But there were no mobile phones, no emails, and the CT scanners were single slice CT scanners that took you 30 different breath holds to go through the entire lungs. Nixon had declared the war on cancer, and because early on, women, the lung cancers and were rising for women as well as for men. But lung cancer screening had a bad rap at that point. There were multiple studies launched by the NCI, headed by Nat Berlin, who was a big supporter later on, and Melamed and Tachman at Hopkins at New York Hospital, and at the Mayo Clinic. And they were all negative, and they were summarized by this statement by David Eddy, who was the chief consultant to Blue Cross Blue Shield. He said, screening with chest x-ray leads to overdiagnosis and other harms, so that screening should not be recommended in general, nor by physicians to their high-risk patients. But I've heard each of those PIs of those 3 trials that were negative say, we absolutely continue to give a chest x-ray to all of our high-risk patients. So we started with many meetings in 1990 to 1992, the planning phase. We read the literature by Betty Flanger, who was the chief statistician for the Mayo Hopkins and Memorial Study. I was at the Brigham and Women's Hospital and spent a year at Harvard Medical School, at Harvard School of Public Health, meeting Olli Miettinen and Alan Morrison. Olli Miettinen is considered the father of modern epidemiology, and he really showed what studies needed to be done to look at screening. And Morrison actually put it how to actually do it in practice, and he was very much involved with the hip breast cancer study as well. So then we invited Dr. Flanger and her student, Dr. Kimmel, to discuss their views of the results of the trials. And they had developed a model for seeing how detection influenced the cure rate of lung cancer. And they said, if you could detect 100% or close to 100%, you could probably have a survival rate of 80%. That was their prediction. And we used that. We also invited Olli Miettinen to come and discuss and develop some of the methodology, with the goal to reduce deaths from lung cancer by finding it earlier, and how to learn about low-dose CT screening in an efficient manner with a small amount of funding. So we came up with this model to screen 1,000 patients, participants 60 and older, with at least 10 pack years of smoking. And we said everybody should get a CT and a chest X-ray. And then we see what the lung cancer distribution, stage distribution, and size distribution is when we use CT and when you use chest X-ray. And we said that's separate from the intervention. Once you have the diagnosis, then separately we will see what the long-term cure rates or survival rates are. So that was our study design that we started. And I want to remind you, we saw 12 CT images on a single piece of film, as shown here. We also had a lot of outreach to our colleagues in New York City and in other places to see if they wanted to be involved in the lung cancer screening project. But at the end, it was only our institution at that time, Cornell and NYU, that participated. And while it took us 6 years to recruit 500 patients at each institution. So while that was ongoing, and it was a very slow and tedious process, we explored other things. We explored artificial intelligence techniques for identifying small nodules, because I called up Rome Labs, because I had worked with them in the military projects before. And I said, well, when you're looking for tanks, what kind of techniques are you using? Are you using computer techniques? They said, yes, we have them, but we rely on people. But we worked together, and that led to the article that we published where they said searching for lung cancers instead of tanks. And we also looked at volumetric growth assessment at that time, and we developed a management system. So that just shows that some of the early photographs, and David wrote 2 very important talks or 2 important papers on volumetrics and how you assess growth. And actually that ended up in a patent to Cornell that said for all tumors in all mammals, we have the patent for assessing growth. And I had to find an earlier picture of David, but that's the best I could do. So we looked at the volume, and the volumes the volume changes are subtle. From time 1 to time 2, you see a slight growth here, or you can see it at time 2 and time 1, you see slight growth here and here. It's subtle, and it still takes a long time to really accurately define growth, but it is a key measure. We can do lots of fancy pictures at that time and showing blood vessels. And there's a lot more that we can gain out of these CT images that we've just started to really touch the surface of. So we ended up in 1999. It took us that long to really get these 1,000 participants, and we found CT identified 27 cancers, of which 23 or 85% were in stage 1. But chest X-ray only found 7 cancers, although they still had a 57% in stage 1. And that led to the Lancet publication. And that morning of the Lancet publication, I said, oh, I can go to work a little later. But no, they called immediately, and there were already people who had read the New York Times article that said, this is a life-saving benefit. And they said, we want the CT scan. And I said, well, wait a minute, if the study is closed, I can't do that. So they said, we're taking the train right to Washington, and we're going to complain that you did not take care of us. And they were both lawyers. So I called the administration. I said, please, can we do a CT scan? So we did CT scans on them for free. And they both had early lung cancers, amazingly enough. So the NCI have a national board of advisors, and they held a session to address the benefit of our article. And the senior biostatistician from Harvard thought the evidence was already there and we could just start screening. But the NCI colleagues said, no, we need a randomized trial. And so it started. But our dean said we should do a study, a confirmatory study in New York City. And all the deans agreed of the medical schools that this would be a good study to perform. So here are the 12 institutions that performed the New York LCAP study, which we then published in 2007, and that confirmed our 1999 Lancet results. When we came to work that day, after the New York Times article, we got hundreds of thousands of phone calls. And luckily, I found an actress, a person who was coming to New York to be an actress, and she could answer all of those calls all the time and say the same thing from all over the world. I was very, for the first time, I truly understood the benefit of rehearsals and practice and being an actress. We started our international conferences for lung cancer screening in October 1999, and we've continued. We'll be holding our 48th conference later, early next year. So it was, and those meetings said they recognized the breakthrough opportunity of CT, and we should develop and ask us to develop an international protocol and have working groups and continue to meet every 6 months, and also recommended funding from the tobacco companies, because they said, after all, they cause a lot of this, they should pay for it. The NCI came to our meeting and proposed their first study, initial study of for the randomized trial, which they then changed. So we developed from 2 institutions in the center to the New York LCAP to ILCAP, and really spread throughout the world. People were very interested in working on this. We've held many conferences with our partners in those various countries, and really, these are true friendships that have continued throughout our life. We developed the ILCAP screening regimen, and as I say, the devil is in the detail, because how do you provide the benefit and minimize the harm? So it's how you acquire the low-dose CT, how you define a positive result that requires further workup, how do you do the workup, all the way to the diagnosis of lung cancer. And that has to be continuously reevaluated and changed and updated. So some of the criticisms we have, people will start smoking again if you have a negative CT scan. So we started working with David Burns, who wrote the Surgeon General's report on the dangers of smoking. And we addressed those concerns. We said that among the 131 lung cancer screening participants who were actively smoking, 23% reported that they quit, and the other decreased their smoking habits. And we really didn't have people who started smoking again. In fact, I would show the CT scan to a person being screened, And they would call me up later on and say, you know, as I crossed the street and I started to light my cigarette, I said, I remembered what you told me about my lungs and about the emphysema. And they said, I put my pack away and I didn't smoke again. So that's where we realized that we have a powerful tool to help smoking. And we also addressed that giving the low-dose CT, a negative low-dose CT, doesn't cause you to, again, start smoking. We studied secondhand smoke exposure together with David Burns and developed a technique of quantifying the secondhand smoke exposure, particularly for people who had never smoked. Because early on, we wanted to really work with all people who are at risk for lung cancer. And we showed that if a never smoker has emphysema, then they're almost at the same rate of having lung cancer as a smoker. So that was an important message. But to date, we still have not endorsed screening for never smokers in the country. So we also looked at other things. We looked at the coronary artery calcifications that we could see on each and every scan. And we said, how can we have an easy way of quantifying them? There are 4 coronary arteries. Each of them, we could say there's no calcification, mild, moderate, or severe. And so each person could have a score between 0 and 12. Later on, we showed that really predicts cardiovascular disease, death from cardiovascular disease. And we also showed that these scores were highly correlated with the Agatston categories of low, intermediate, and high risk. And we showed for these, using our secondhand tobacco score, that the more secondhand smoke you have, the more likely you are to have coronary calcifications. So that was an important breakthrough early on in comprehensive screening. We also looked at the pathology. And so here we see a tumor or a nodule that appears solid, and the pathology specimen shows that it's solid. There are no more aerations or in that specimen. But then we also saw part solid nodules where you have where you still have some aeration in the alveoli, or you have a lot of aeration in the alveoli. So that we called a non-solid nodule and a part solid nodule. And we realized that they had different types of aggressiveness, that a non-solid nodule today, we follow for 1 year and see if there's any change, if there's any emergence of a solid component. So these are all things that we had to learn. And we did that together with American Cancer Society sponsored panels of pathologists. We invited Bill Travis, Elizabeth Brambilla from France, Daryl Carter from the US, Adi Gazdar from Texas, and Masayuki Noguchi from Japan. All of them had been interested in early lung cancers, and we reviewed all of these cases, and they said, yes, they all look like lung cancer. They agree that they're lung cancer, but they'd never seen such small lung cancers. So that led to new descriptors that we now use today: atypical adenomatous hyperplasia, adenocarcinoma in situ, and so on. So screening, early detection of any disease causes a whole consequence in all of the other disciplines that touch that particular disease. So in 2002, Andrew von Eschenbach, who was named director of the National Cancer Institute, announced the start of the NLST, the National Lung Screening Trial. It was a randomized controlled trial of high-risk individuals randomly assigned to 3 rounds of low-dose CT screening, but compared with chest X-ray screening to see if low-dose screening could lead to a mortality reduction of 20%. So we were always very worried about the results. And in between, in 2006, the lung cancer cure rates were still very low. The case fatality rate was 95%. And so the cure rate is 1 minus the case fatality rate of 5%. So by then we had accumulated, because we continued screening with our screening protocol, we'd accumulated over 31,000 individuals. And we said, let's look at the cure rates or the survival rates that we can now produce. And we said that if you take all cases diagnosed under screening, late stage, early stage, all together, the long-term survival rate was 80%. And if it were in clinical stage 1, it was even higher. So a lot of people said, oh, this is overdiagnosis, lead time bias. This can't possibly be true given the statistics at that time. So we got a lot of controversy at that point. In the meantime, the NLST was continuing. So that paper came out in 2006. In 2011, the NCI announced that the NLST had shown a 20% mortality reduction. And then the US Preventive Services recommended annual screening. And in 2021, the Nelson study was published, and that that lowered the rates, the enrollment rates to 50 to 80 with 20-pack years of smoking. And each of those steps increased the screening program for individuals, but we still have a long way to go. So at that time, the NLST was announced. Jim Malshine, who we've worked with all this time, said that's the greatest single reduction of lung cancer mortality in the history of the war on cancer. So it shows the power of prospective data collection, which really had been recommended by the Institute of Medicine way back when. They said we should collect information through our clinical care and provide constant updates. We had these very small images, and now we have very big images on big monitors, so we can see many small nodules that we could not see before. And we've collected a database that allows us to do AI for making the whole process of reading the CT scans and reading the subsequent scans in a more efficient manner. And David will talk a little bit about more on that. So we look at whether a new CT scan, whether there's been no change, no new nodules, no size changes. But it's not that simple, because these are small, tiny nodules, as you see here. And this is 1 year, and a year later, you have to find it in the image again among all the other nodules. And you have to very carefully assess a size change, which is also difficult, because here's a part solid nodule with a solid component and a non-solid component. How do you really assess those changes? So it takes a lot of work still to do that. So now we've accumulated more than 100,000 individuals throughout all the countries. And we said, what is the cure rate now with this bigger, longer term follow-up? And we said it's still 80%. So at this point, all of the former naysayers said, no, we believe the results at this time. And that is correct. And just to show it more clearly, this is a slide from Doug Wood. This is without screening, the lung cancer survival, and this is what it is in ILCAP. It's a dramatic difference. And the New York Times mentioned it. We got the award for the best scientific paper of the year for that. But this is the most exciting part. Now we can look at the CT scan for all of the organs that we see in the CT scan: the heart, the lungs, the bones, the breast. And even though we started that in 2004, you see it takes a long time. Now in 2025, at our last meeting, this was fully endorsed that comprehensive screening is the way forward. And we wanted to look at what is the long-term follow-up of those coronary artery calcifications. And we see that if you have at baseline a CAC of 0, then this is your long-term survival. If it's greater than 0, it's lower. And again, for each of the different categories. And we can do the same for emphysema. So there's none, mild, moderate, severe. How does that on the first CT predict the future? And it's a similar way. If you have no emphysema, you do better than if you have emphysema, and it depends on the degree of emphysema. So now we have the techniques that we can, when we do the first scan of an individual, let's say there's a 65-year-old male who smoked 48 pack years, no history of diabetes, and we see his CAC score, we can say, well, in 25 years, if you have, depending on your CAC score, these are your survival rates, and for emphysema, these are your survival rates. So you could really influence them and to have them change their lifestyle and their risk factors based on data. So you have to keep rethinking and optimizing all components of the diagnostic treatment paradigm of a low-dose CT. There's still millions of people who die every year, so it has to spread throughout the world. We helped Croatia, the first European country, start its screening program, which has been very successful. We're working with people from the researchers from Kazakhstan, which have a high lung cancer mortality as well. And we're also working with Latin America and Africa in all of those countries. In all of those countries, lung cancer is really underreported because it's mixed up with drug-resistant tuberculosis or other things. So we're working on that jointly. So remember, it takes persistence, perseverance, and an ever-expanding team. Thank you very much.
Okay, I'll just continue a bit with some challenges and opportunities. These are my disclosures. And Claudia mentioned that the NLST started shortly after. We came out with LCAP results in 1999. And in 1999, and by 2002, the National Cancer Institute initiated a full-scale randomized trial. It's almost unheard of to have moved that quickly. So our article really stimulated them. They were actually very concerned that screening was going to take off and they hadn't done the trial. So this was their protocol. And we looked at it very carefully. So we had shown that, smaller cancers are better. And so in their protocol, they really challenged this idea. They said, well, let's hold on. And they said, it's really about the biology. And maybe it's nothing to do with size. And here's from their protocol. We do not currently know that outcomes are necessarily better when the cancer is 2 millimeters as opposed to 20 millimeters. And therefore, as purveyors of public policy, they really need to test this. So that was the theory behind why this was their rationale. And it's just important to step back and think about that. At least that's the way we thought about it, that is it really a question whether 2 millimeters is better than 2 centimeters? Or instead, is it really a question of how much better? Is it this hypothesis testing, or instead is it a quantitative? Because it just seemed, if you can say that we don't know if 2 millimeters is better than 20, then it's safe to say you can let it grow from 2 millimeters to 20 millimeters before anything needs to be done. And to show you that I'm not, so this is their consent form, and they tell the patients who enrolled, lung cancers are biologically heterogeneous and size alone is not adequate to explain their behavior. And we know that CT detects smaller tumors than chest X-ray. But regardless, that was the rationale for why they did it. The unofficial rationale was that they wanted to prove Dr. Henschke wrong. That was really the unofficial rationale. And I know this because I knew many people in NCI, and the things that went on were just quite extraordinary. But this is, again, this is the staging system, and you see, smallest tumors, look at their survival on the top, the small tumors, and this is from the ISLC, 95% cure rates for, these less than 1 centimeter tumors. So the numbers are, kind of make sense. So Claudia had mentioned Oli Mietnin, who was really considered the father of modern epidemiology. He was a brilliant guy. He developed all the foundational theory for biases, controlling for biases, the whole concept of confounding by indication. All of these were his theoretical concepts. And Claudia had worked with him when she was at Harvard, and he was one of the people that we worked with in developing our protocol. And this is the difference between what LCAP did and what the traditional approach was. LCAP's approach on the top was screen everybody, learn the distribution of cancers you get, and then see what potentially would happen if you treated immediately versus delayed treatment. So we separated the prognostic arm from the diagnostic arm. We said this could be studied separate from this. And this you could learn very quickly, potentially. If you had enough people, you could learn all of this information. And this gave you quantitative information. This is the traditional randomized trial where you randomize to the screening test. You randomize, in the case of the NLST, you randomize to CT versus chest X-ray. And in the CT arm, you get early diagnosis and early intervention. And the chest X-ray arm, you get late diagnosis and late intervention. Typically, this is done with a couple of rounds of screening and then long-term follow-up. And you get mortality reduction in this. But you tend to get results that are sort of hypothesis testing. You don't get the extent of the benefit. You get 20%, you reach 20%. Does that mean that you're not curing more than 20%? The trial sort of stops, and it takes a long time. And during that time, when you stop screening and you're just following, you get a lot of what we call dilution. But these were the two alternatives, and I can tell you there were many long debates about this. This became almost fanatical, the level of commitment to traditional randomized trials versus, and so that was one of our battles. This was the results, as Claudia has shown from LCAP. We showed that we had long-term cure rates that were high. We were getting up to 80% cure rates. And we say cure because you can see that the curve, the survival curve flattens out. And once it flattens out, you're in essence at the cure rate of that cancer. People are no longer dying from lung cancer. And this has now been shown, other groups have now shown this, and it's now being reported. At the time, this was not a very popular approach to talk about cure rates. This is the result from the NLST. 247 deaths per 100,000. This came out in 2011 per 100,000 life years versus 309, and the difference there is 20%. And that's the really famous 20% mortality reduction. And this, really resonated. I mean, it became a very important finding, and congratulations for them doing that. But here's how this was interpreted. I think this is really important. So this was what was written by, very prestigious organizations, the American College of Chest Physicians and the American Society of Clinical Oncology. This is how they said, physicians, they put this is what they said, that based on the NLST, this is what a physician should tell his patient interested in screening. Components of a conversation. 4 out of 5 people who are going to die of lung cancer will die of it even if they're screened. Screening prevents 1 in 5 deaths from lung cancer. They directly interpreted that hypothesis test result at 20% into what the curability was, in essence. So they said, and this is, so 1 in 5 deaths. And here, this is Russell Harris, was from the American Academy of Family Physicians, who were the last group to endorse lung cancer screening. As screening and early treatment delays deaths for only 20% of patients destined to die, 80% of screened people with fatal cancer will die. So that's how they interpreted that NLST result. Now, you heard what Claudia said, we're curing 80%. So this is the time where often I've given this this aspect of the talk before, and I asked the audience, do you agree? Which one of these do you agree? Are these measures compatible or incompatible? I mean, how do we interpret all this? Here, LCAP is saying 80% are cured. NLST says 80% you're going to die. 4 to 5 you're going to live. 4 to 5 you're going to die. It's really an extraordinary dichotomy with the #1 cancer killer. So The short answer is there's nothing inherently incompatible with saying that the NLST had a 20% mortality reduction. It did. It had a 20%. But that 20% is contingent on the design of the trial. They screened for only 3 rounds. They followed for 7 years. You get a 20%. If you followed longer, followed for 10 years or 15, now it's down to 10%. So the mortality reduction in a trial like NLST is very dependent on the parameters of the trial, the number of rounds of screening, the length of follow-up, that sort of thing. Whereas the cure rate is the cure rate. So there's nothing incompatible with NLST showing that. And in fact, when we look at the NLST long-term survival of the cancers they found, it starts approaching the same results. So in our mind, the 80% is one of the critical things. Now, this is a source of serious confusion. And we actually did a study where we did these structured interviews of patients or potential screening participants as well as clinicians here at Mount Sinai. We did this study. To my surprise, when you tell patients about the 80%, 20%, and which one is more meaningful to you, it was not as much of a wow as I thought it would be. I thought patients would say, well, my God, patients in general felt, I'm going to get some benefit. That's the most important thing. The extent of the benefit for some people was important, but for the majority it was just, no, I'm really interested in this because I'm going to get some benefit. For the clinicians, however, it was enormously different. They found that topic very confusing. They didn't know what to make of it. They found always confusing. They wind up just relying on their own sense of we think it's probably good or probably not good, that they really didn't get this. And so it's leading us to say that we really need to push the societies to make this distinction very important, that there's a consistent message out there. So that's part of the direction we're going. We're actually working very closely now with the American Cancer Society to standardize this. Now, I wanted to talk a little bit about some of our controversies, and we've had our share. Raja alluded to some early on. The study design issues were some. This was one. We came in 2010 to Mount Sinai. And, we came with our whole lab, and it was a wonderful time. We're new recruits here at sort of the honeymoon period. And in that honeymoon period, one day, I'm doing a biopsy downstairs, and one of the clerks at the front desk comes, says, there's a friend of your mother here. She's not doing well, and they really want to speak to you. So I say, oh, should I run outside? Next thing I know, I'm handed this piece of paper. It's a subpoena from Philip Morris. Now, in Philip Morris, in 2011, Philip Morris subpoenaed LCAP to obtain access to comprehensive screening data. And the request was not a little request. They said, we want to see every single CAT scan. We want copies of every single CAT scan you performed, every single pathology slide you have, every single manuscript you've written, early drafts of the manuscripts, rejection letters from the manuscripts, every letter, every grant you've applied for that wasn't funded, everything you could think of, every email between the two of you and your collaborators. It was enormous. It was just enormous. So you can imagine, going to see Dennis Charney at that time and saying, hey, Dennis, we got to defend this, And now the honeymoon ended very quickly. It was, but to Mount Sinai's credit, they put us in touch with an outside law firm, and they gave us 2 wonderful lawyers, one of whom is now here. Beth Essick was one of the lawyers who helped defend us. It turns out that Beth had also defended Irving Selikoff from the Selikoff with all the asbestos. So she had a lot of experience with this kind of stuff. But it was something, Mount Sinai positioned themselves as the David and Goliath fight. You don't realize just how big tobacco is. I mean, Mount Sinai was, we're just this little hospital, and it was amazing because, I'd sit on, some of the, the conferences between the lawyers, there'd be like 1 or 2 lawyers representing us, and Philip Morris would have like 15 lawyers on the same call. I mean, it was just incredible. But and the reason for this, which is important, why did they subpoena us? Because they were being sued by several states to pay for statewide screening. So the big one, the first one was Massachusetts, but several others, New Jersey, California, Arizona, Utah, they were all suing, saying, hey, you guys caused the problem. You're therefore responsible to remedy the problem, and you should be paying statewide screening. This is now billions of dollars they were being sued for. So they wanted to defend themselves in this, and they said, we can't defend ourselves based on your published work. And we were the only evidence being put out there saying screening works. We're the basis. So now they're hiring all kinds of people to say our studies are terrible, they're no good. You know, and these are people, many of them are colleagues of ours they're hiring to work for Philip Morris to, you know, put down what we're doing. And they're paying enormous amounts of money to do this. So that's what we were up against. But, you know, I tell you, Mount Sinai, you know, stood tall in this, and we were eventually able to settle the case without giving any data up. I also was quite lucky because during that time we were the only evidence. But during the year or so that we were working on this, the NLST also came out with their results. So there I am saying, you know, the NLST, I have worries about its design. I was saying, go look at NLST. That's where you got to go. We're just this little study. It was real, you know, the situation can make you change your views very quickly. So it was really something, but it worked out well. I also wanted to just talk briefly about the initiative for our treatment side, because as I said, we've gone from the diagnostic side to now we're much more in the prognostic mission, and we study this separately. And this became our own separate consortium. And its mission was to translate early diagnosis into improved survival through minimally invasive treatments and biologic understanding. And we set up a consortium of hospitals, the whole Mount Sinai system, the Northern Westchester system joined us, the North Shore LIJ, that whole group. Northwell is part of the consortium. We have groups in Poland and now in the Netherlands are joining the ILCART consortium. We now have over 3,000 stage 1 lung cancers in this consortium. And we're doing lots of very innovative studies. This is the leadership of it. You can see our own Dr. Flores, and Dr. Henschke, Dr. Emanuela Taioli, and myself are kind of the leadership of this project. It started in 2016. And these were some of the basic questions that we started to focus on. The optimal extent of surgical resection for curative treatment of stage 1. If limited resection is performed, what's the minimal tumor normal tissue margin needed to minimize recurrence? The extent of lymph node resection. Is stereotactic radiotherapy acceptable alternative, not just for those who can't go to surgery because they're too medically compromised, but as a real alternative? Under what circumstances is radiotherapy potentially an alternative? These are the kind of questions we're asking. Is watchful waiting a genuine alternative that's reasonable in certain cases? And consequences of quality of life. So all of these are questions that we've really worked on. Many of them we've answered to our satisfaction. Some we're still working on. We're doing trials. And we're going in future directions now. We're expanding the whole concept of precision therapy integration, broadening biomarker discovery, and we're working to have our protocols be implemented really around the world. And we're working in Central Asia, Africa, Latin America. It's really been rapid expansion. Now, I just want to say, one of the things I wanted to say at this point was we've had the great fortune of having these fantastic fellows work for us. And many of you who have fellows know just how fantastic that can be, and the dedication of these fellows. Since 2015 till now, we've had over 35 fellows pass through our labs. And the thing I notice about fellows is when they get involved, and I give this credit to Claudia, they become so involved that they become almost, this is all they think about. They really focus on it. And I want to give you the example for why, just how much they think about it. So many of you may know that we have a rock star here. We have our own actor here. And so our fellows, I sent them this picture, who's in the movie now, The Smashing Machine, with The Rock, Dwayne Johnson, the most famous. I said, do you recognize them? She says, I recognize Dr. Flores. Who's the other guy? So that gives you an idea. Anyways. With that, thank you all very much.
I'm gonna get you for that one. So questions from the audience, Monica?
Say, this has been a real joy to have you present today. I love doing with other departments and including multidisciplinary medicine for this wonderful presentation and you're telling us about your amazing journey, as it has been. And I think it continues. I can see a lot more collaboration, certainly from the department in the future, so look forward to your conversations. Question actually around secondhand. And I know that so you don't have the screening guidelines for that, but I can say even from a personal note, I had a lot of exposure to that as a child. And even though I never smoked, it would be bad since I'm a pulmonologist. But on the other hand, I worry about risk. And what can you tell us about that? Do you think one day there'll be guidelines for that? I know some of us do it anyway, but I'd love to hear your thoughts on where that's going.
So on the data that we had, there are many more coronary artery calcifications and coronary artery deaths, so that we could show that relationship. There are fewer lung cancers, so we could never really show a statistically significant, but it clearly is. It makes so secondhand smoke, and we keep working on this. Sooner or later, never smokers, I think. So we screen never smokers in our program here at Mount Sinai. And we get the secondhand smoke exposure score on all of them. So maybe eventually we'll be able to convince people.
This is another one of those areas, by the way, that I say we had controversy. So we were screening secondhand smokers. We published some articles on this. The next thing I know, Mount Sinai receives an anonymous letter that we're causing all this harm. We shouldn't be doing this. Next thing I know, there's investigations. And, Glenn Martin had to write letters defending us that this was like the worst thing that could be done. Now, 10 years later, NYU is doing a program on secondhand smoke. It gets New York Times coverage as like the greatest thing. But there is a lot of work going on. There's now been a renewed effort. The IASLC, which is the major organization for one of the main societies on lung cancer, they just set up a special committee now that's exploring how to set guidelines for people exposed to secondhand smoke or never smoking. So there's enormous renewed interest in this now. Dan.
So at 45, or less fatal prevalent cancer, what further proof do we need to get CT scan at 35 years old for someone who's never smoked?
So I usually, early on, I looked at the Japanese. The Japanese, by the way, when you look at their lungs, because they collaborated with us, they're so much better than the New York City lungs. But they started really screening with chest X-ray at age 40. And I think that's a reasonable age for everybody to get a low-dose CT scan. And then maybe long-term, 5 years, 10 years later, depending on their risk characteristics, to get another test.
Yeah, this idea now is coming up more and more, this comprehensive screening. And that the amount of information you're going to be seeing article after article now about what we can extract about the heart and heart disease, the lungs, emphysema, fat distributions, muscle quality. This is going to be a revolution. And we're just knocking at the door now. But our sense is that there's going to be a scan at some age, whether it's 35, 40, you'll get that first scan because that's when things start to, and they're highly predictive into the future, and it gives you a chance for lifestyle change. But we really do think that that's where this is all heading. Dr. Wolf.
This is a non-lung cancer screening question. Maybe controversial more to some people, but you gave us the most insight I've seen in the last 15 years into the sort of secret sauce that is really an organization from a leadership and culture standpoint. What's the magic? How did you do this? How do you have these fellows and collaborations all over the world that are 25 years, 26 years standing?
I can answer that easily.
Claudia.
That's it. It really has, become almost, I always thought this was trite or quaint to say that we became almost like a family, but it has a lot of that. Some of these people have come, we've had 48 conferences. I have people that have come to all 48 conferences. Sites that have worked with us, they've become very close friends. It's just been a remarkable journey. The fellows stay in touch with us, they spend a year, 2 years. They're writing me on WeChat and, it's just, I don't know. It's been an extraordinary journey. And I give this all credit to Claudia.
It's the excitement of the topic and looking at the various components and then seeing how they're applied and how they change the life of a patient. And a lot of our participants, our study coordinators talk to them and they call me, they sit down with all of us and talk about it. It's the detail and the connections to the participants, but it's the multidisciplinary aspect, the medicine, the pathology, the surgery, the oncology, all of those components are really critical.
I can sum it up. Claudia leads with the most powerful human emotion on earth, love. And that's the foundation of this organization. All right. Well, thank you, everybody. Monica, thank you again. This was awesome.